Welcome to the Human 5.0 Project, the podcast where we cut straight to the breakthroughs that matter, the show where science meets self-optimization. I'm your host, Ultimate Biohacker 10X, and here we break down the real research, real data, and real dosing behind modern biohacking, from compounds and peptides to techniques, devices, lifestyle strategies, and performance protocols. Most people jump in and jump out before they get the gold, so we're keeping it tight and delivering the essential insights you need without the fluff. If you've taken the time to hit play, we'll make sure you walk away with valuable knowledge that can transform your approach to longevity, health optimization, and beyond. This episode is a little bit different because a friend of mine has a family member suffering from a condition that is a little bit unusual. So I figured I would do what I could in order to get some information out there that would help anybody else suffering from the same thing. Recurrent laryngeal nerve paralysis after carotid endarterectomy. I know that's a mouthful, but basically what it means is you've got vocal cord paralysis after having neck surgery for a blood vessel, and it could be for something else. This is one of those complications that can wreck the quality of life fast. Hoarseness, weak voice, cough, aspiration risk, sometimes breathing issues. And here's the truth. Traction injuries often improve, but wait and see isn't a plan if someone is struggling to speak or swallow. Today we're breaking down every serious modality on the menu. Speech and voice therapy, swallow rehab, biomechanical fixes like injection laryngoplasty and medialization, Reinnervation, and what's actually happening with laryngeal pacing and electrical stimulation, plus a sane evidence-based supplement lane for peripheral nerve support. Adjunct only, of course, not magic. There's no hype, there's no miracle peptides, just a clean, compartmentalized field guide. Okay? Welcome back to the Human 5.0 Project. This is Ultimate Biohacker 10X, straight facts and zero filler. This is for educational purposes only and not medical advice. You should be in active communication with your surgeons and primary care specialists throughout your entire process. Cool? All right, let's move. RLN paralysis can be unilateral or bilateral, one side or both sides. Bilateral vocal cord immobility can be an airway problem, and that's an urgent evaluation. Dysphagia, with coughing on liquids, choking, and recurrent pneumonia, weight loss, is also urgent. If this is post-op, the correct first move is ENT otolaryngology evaluation with laryngoscope or stroboscope to confirm what's actually paralyzed and how it's compensating. Also, recovery, prognosis, and treatment timing depend on severity, duration, and etiology. For instance, traction neuropraxia versus transection versus compression. Cool? All right, now we can talk. The recurrent laryngeal nerve is a branch of the vagus nerve. It drives motor function to most intrinsic laryngeal muscles, controlling vocal cord movement and closure. After carotid endarterectomy, hoarseness can occur, and a subset of cases are true vocal cord paralysis from nerve injury, often traction-related in the surgical field. Older data reports postoperative hoarseness and confirmed vocal cord paralysis in a minority of patients. The key clinical question is this paresis or weakness, or is it paralysis, no movement? And is the airway protected? Symptoms cluster into three buckets: voice, hoarseness, breathy voice, low projection, vocal fatigue; swallow, coughing and choking, aspiration, a wet voice after liquids; and breathing, stridor, dyspnea, especially if bilateral or poor abduction. Now, most traction injuries are neuropraxic spectrum, meaning time and rehab and protection can lead to improvement. But the patient experience during that time can be brutal, so the job is to support the function early. Let's start with the non-sexy answer that actually works: speech language pathology, or SLP. So, what's at the core? Voice therapy. For many unilateral cases, voice therapy is first line because it improves glottic closure strategies, reduces maladaptive tension, and can improve projection and fatigue. Practical categories for SLPs: what do they use? Vocal function exercises, systemic practice for strength, endurance, closure, efficiency; resonant voice, semi-occluded vocal tract drills; straw phonation, lip trills. This reduces collision forces while improving output; effort closure and adduction tasks when appropriate. Careful, don't overtension the supraglottis. Respiratory phonatory coordination, such as breath support and phrasing. Best take here, therapy often helps, but it's technique dependent and clinician dependent. The right SLP, one who does voice disorders all day, is a different universe than a generic speech therapy. Next, swallow therapy. This is the aspiration prevention lane. If dysphagia is present, this becomes priority. Swallow therapy may include compensatory maneuvers such as head turn, chin tuck, depending on findings, bolus modification, which is the amount of food you eat in a bite or a swallow, cough training, airway protection strategies. This part is not optional if aspiration risk is real. If the person is coughing on liquids, that's a clinical lane. All right, next, manual therapy, myofascial laryngeal massage. This can help when compensatory muscle tension dysphonia develops, neck tightness, strap muscle overactivation, jaw tension. It won't heal the nerve, but it can dramatically improve the functional output. Next, electrical stimulation. Important nuance here. E-stim is more established in dysphagia rehab contexts than in restoring true RLN motor recovery. There's ongoing research and mixed results depending on target, technique, and patient selection. So treat this as adjunct for selected cases under experienced clinicians, not buy a device and fix a nerve. Here's the big mistake: waiting months while someone aspirates or can't speak. A. Injection laryngoplasty, or IL, the bridge that often saves the patient experience. Injection laryngoplasty is an office-based or procedural injection to medialize the affected vocal fold, improving closure, voice strength, and sometimes swallow safety. Why does it matter early? Well, it can give immediate improvement while waiting to see if the nerve function returns. It can reduce aspiration episodes in some post-op settings, and evidence supports the utility and safety of early IL in appropriate patients. Material choice determines durability, temporary versus longer lasting. The bridge concept is key. Support function while biology plays itself out. Next, medialization thyroplasty, type 1, plus or minus a retinoid adduction, the structural fix. If paralysis persists and symptoms are significant, framework surgery can permanently improve closure, often high satisfaction for voice, and can help swallow safety depending on the mechanism of aspiration. Next, reinnervation, ansa cervicalis into the RLN, for tone restoration strategy. Reinnervation procedures aim to restore tone and bulk, sometimes improving voice stability and reducing atrophy over time. Systematic reviews describe outcomes and the role of reinnervation as a durable option in selected unilateral paralysis cases. Important, reinnervation is not instant. It's a month's timeline. Next, laryngeal pacing and functional electrical stimulation, the frontier lane, especially for bilateral issues. This is where things get interesting. Laryngeal pacing is being developed to stimulate laryngeal muscles dynamically with the goal of improving opening for breathing or coordinated function. A state-of-the-art review describes unilateral and bilateral pacing systems and notes active clinical trial development for bilateral vocal cord paralysis. Also, there are preclinical large animal models exploring functional stimulation of laryngeal muscles. Translation: promising, real engineering. Not yet routine standard of care everywhere, and best accessed through specialty centers and trials. So let's be disciplined. No supplement has RLN paralysis specific randomized controlled trials that solves this, but peripheral nerve support data can inform a rational adjunct stack, especially if deficiency exists. The check first rule: if you can, labs for B12, folate, iron studies, vitamin D, magnesium, and metabolic markers. Correct deficiencies first because deficiency turns recovery into an uphill climb. Evidence adjacent, reasonable options, which would be adjunct, vitamin B12, especially if low or borderline. This is important for nerve function and it's used in neuropathy contexts. Alpha lipoic acid, studied in diabetic neuropathy for symptom improvement. Omega-3s, EPA, DHA, anti-inflammatory support, and membrane health. Magnesium supports neuromuscular function. Deficiency can worsen cramping and tension and sleep. I'm intentionally not giving protocol cosplay dosing here because this is medical territory and patient-specific. Comorbidities, meds, renal function, bleeding risk, etc. The role of supplements here is support the biology, reduce inflammatory drag, improve sleep, and rehab capacity, not regrow a nerve overnight. Okay, experimental, off-label, and cutting edge. Again, experimental, off-label, and cutting edge. I've mentioned things like cerebrolysin, dihexa, and other neurotropic compounds in the past. Here's the correct framing in context. These are not standard RLN paralysis treatments. Evidence is limited, indirect, or preclinical, and quality varies widely. Some compounds marketed online are research chemicals with serious purity and safety concerns. If you're going to explore this category at all, the safest lane is clinical trials or specialist-guided care in legitimate settings. So in this episode, I'm not endorsing them as do this. I'm labeling them as investigational concepts. Neurotropic signaling, synaptogenesis support, anti-inflammatory, neuroprotection, but outside trials, risk-benefit is often unclear. If someone is struggling right now, the highest yield moves are still SLP and swallow safety and early IL when indicated, especially ENT follow-up. So if this is a traction-related recurrent laryngeal nerve dysfunction after carotid endarterectomy, here's a clean pathway. Step 1. Confirm diagnosis and risk. Laryngoscopy and stroboscopy. Determine unilateral versus bilateral. Assess aspiration risk. Step 2. Start rehab immediately. Voice therapy with voice-specialized SLP. Swallow therapy if dysphagia. Home program and monitoring. Step 3. If function is significantly impaired, bridge early. Consider early injection laryngoplasty when voice and swallow needs immediate support. Step 4. Reassess over time. If recovery occurs, taper interventions appropriately. If persistent impairment, discuss thyroplasty and/or reinnervation options. Step 5. Frontier options. If bilateral issues or severe functional problems, ask specialty centers about pacing stimulation developments. Bottom line, recurrent laryngeal nerve paralysis after carotid endarterectomy is a quality of life injury with real risk: voice, swallow, and airway. The highest yield modalities right now are not exotic: SLP-led voice therapy, swallow safety rehab, and early procedural support like injection laryngoplasty when appropriate. Then, if needed, medialization surgery, reinnervation, and for select cases down the road, pacing tech that's finally becoming real. No fluff, no false promises, just a clean path forward. Stay strong, stay informed, and stay rehabilitated. This is Ultimate Biohacker 10X, and I'm out. Thanks for listening to the Human 5.0 Project. If you found value in today's episode, share it with someone who's ready to elevate their biology. Make sure to follow the show for weekly deep dives into peptides, protocols, devices, lifestyle strategies, and the science of high-performance longevity. Until next time, stay curious, stay optimized, and stay 10X.